pharmacist. I have been practicing in long-term care for a number of decades. I have seen many different things happening over the time that I've been in long-term care. And I'm really excited to still be practicing today with all of these changes that are happening from a regulatory perspective and from a funding perspective. There is never a dull moment. I'll just leave it like that. But we're going to present today on Parkinson's disease psychosis. So for the next hour, we're going to chat about management strategies for Parkinson's disease psychosis, particularly. And there is a chat, if you've already found your chat. I'm going to open up the chat so that if you've got any questions as I am going through this information, you can write it in the chat. I'll be glancing over there. And please, I'll stop and ask for questions too. So if you're more comfortable just blurting out verbally, I'm fine with that. We have a small group today. We have time to make sure we answer everyone's questions. So with that, I'm going to jump right in and let's see if I can get my slide deck to progress. So we have objectives, and first and foremost, we want to discuss the psychiatric symptoms that are present in people with Parkinson's disease. And then we're going to focus specifically on the Parkinson's disease psychosis, which is hallucinations and delusions, and understand the impact that this has to caregivers, and particularly caregivers in an institutional setting. And then we will talk about current and emerging treatments, and then formulate a strategy that each of you, dependent on what your position is in caring for people with Parkinson's disease, but each of you should be able to take something away that you can implement in your job activities. So that's our goal for the next little bit that we're together. And this is me. I am a speaker for Acadia Pharmaceuticals. They do have a product that treats Parkinson's disease psychosis. And I'm a consultant for a number of other companies that are not in the Parkinson's disease space. But I promise you we will make this very non-biased. So jumping right in, Parkinson's disease is commonly thought of as a movement disorder. And you probably have learned in school the cardinal symptoms of Parkinson's disease is recognized by the acronym TRAP: a tremor at rest, rigidity, akinesia or bradykinesia, which is slowness of movement, and postural instability. And you can see that in the graphic over on the right. This old gentleman, he tends to have the tremor, and it could be in his head. More commonly, it's in a hand. I'm trying to get it up here where you can see it. It's in a hand, and commonly it's what we call a pill rolling tremor. It's a large magnitude tremor and rather slow. That's different from an essential tremor that is like this. Another thing that you can use to differentiate a Parkinsonian tremor is it's typically one-sided. So that tremor will be on the left side of the body until very late in the progression of Parkinson's disease. And then you may see it in a symmetrical, unilateral, where it's happening on both sides. But the majority of our people will have the tremor on one side. Those are the common cardinal symptoms. You also get a mask-like expression where they just have this blank. A lot of times it's misperceived as a depressed look because they don't have a lot of animation in their face. Their voice becomes very soft. We see a lot of drooling because there's an inability for them to swallow their saliva, reduced blinking, shuffling steps, and this can lead to freezing and then falling. And we also see small handwriting, not that our residents are handwriting very many things, but these are the typical motor symptoms of Parkinson's disease. We're fortunate if someone is recognized as having Parkinson's disease in the nursing facility and diagnosed after they come into the facility. Most of the time, if they don't already have a diagnosis of Parkinson's disease, then many of these symptoms, including the cardinal symptoms, oftentimes just get considered as, well, that's just the way he is. He just always sits there and talks real soft like this and doesn't raise his voice. So we need to be looking for these cardinal symptoms of Parkinson's disease, just in case the person had never been diagnosed. I will tell you, as many as 30% of people with Parkinson's disease do not express the hand tremor. They don't have a tremor at all. And if you don't have the tremor, and all you have is slowness of movement and postural instability and rigidity, well, that's just old, right? Old people, they're stiff, they're slow, and they tend to fall down more. And so if you don't have that tremor, that person may never have been sent to a neurologist to have had a diagnosis of Parkinson's disease. And a lot of our general practitioners in internal medicine are unwilling to make a diagnosis of Parkinson's disease without sending that person out to a neurologist. So all I'm saying here is that we could very well have people in our facilities or people under our care that have Parkinson's disease that has not yet been diagnosed, and therefore they don't have it in their clinical record. So that's the most important thing, is don't assume that everybody with Parkinson's disease in your building already has the diagnoses. Your staff, yourself may be able to recognize that this is an ongoing disease. And then once we know that they have the disease, we can treat them. Now, we're not going to focus on treating Parkinson's disease today. We're going to focus on treating one aspect of Parkinson's disease, which is one of the non-motor symptoms. So you can see on this slide, there are actually more non-motor symptoms than motor symptoms when it comes to Parkinson's disease. And psychosis is listed first, not because it's necessarily the most prevalent, but because it's the most problematic. Now, a lot of people with Parkinson's disease will develop depression. In fact, often REM behavioral sleep disorder is a prodromal symptom that occurs as far as 10 years before a diagnosis of Parkinson's disease is made. Excessive daytime sleepiness, probably because they're not sleeping well at night. Cognitive impairment is also a part of Parkinson's disease. Orthostatic hypotension, urinary symptoms, constipation, digestive issues. All of these are considered non-motor symptoms of Parkinson's disease. But today we're going to focus just on treating the psychosis, because treating psychosis, particularly in a nursing home environment, comes with a lot of regulatory oversight, because they want to make sure that if you are having to treat psychosis, that you have attempted all non-pharmacological approaches, and that if you do choose a pharmacological approach, it is a recognized or FDA approved approach, and it's the one that's least likely to cause adverse effects, so that you can minimize the risk of adverse effects. This is really putting F757 and F now 605 in practice when it comes to treating Parkinson's disease psychosis. So what is the psychosis of Parkinson's disease? We have two components of this psychosis. It's very classic for people that have alpha-synucleinopathy. So if you remember, in Parkinson's disease, you have protein deposition in the brain that forms Lewy bodies. They're named after Dr. Lewy, who was the first to discover these protein deposits in the brains of people that had shaking palsy. That was actually how Dr. Parkinson's described the disease that later got named after Parkinson's disease. We discovered that in that disease, if you do a brain biopsy at death, I always suggest waiting till death to do a brain biopsy, and you open up the basal ganglia, you would just see a massive amount of these Lewy bodies or protein deposits, which we now understand are made out of alpha-synuclein. Alpha-synuclein is a very necessary neurotransmitter in the brain. It's necessary for us to learn that very high levels of it are present in a soluble form in young people. But as we age, if an event happens and we don't really truly understand what the event is, it could be genetic, it could be exposure to chemicals, but it causes the alpha-synuclein to deposit into plaques of alpha-synuclein called Lewy bodies between neurons. Now that, if it's in the basal ganglia, it will impair motor movement, thus the motor symptoms we see with Parkinson's disease. But it can be present throughout the brain. It's not just in the basal ganglia. Those alpha-synuclein deposits are everywhere throughout the brain. And depending on where they are, you get different symptoms. So when these alpha-synuclein deposits affect the serotonin system of the brain, and I'll show you this in a minute, we get visual hallucinations, and then as the disease progresses, we get delusions. Now, the visual hallucinations are by far the most common, but we do see other hallucinations like auditory hallucinations, olfactory things, smelling things that are not there, gustatory, tasting things that are not there, tactile, feeling things that are not there. But 70% of people that have hallucinations with Parkinson's disease have visual hallucinations. And if they have an auditory hallucination, it's an auditory component of their visual hallucination. The most common, seeing small children or small animals. And we hear this all the time in the nursing home or even in assisted living where somebody comments, Mrs. Jones is seeing the children again, or Mrs. Jones is saying she's hearing children running up and down the hall. I must have run into that 1 in every 10 nursing homes that I consulted in. And that was an example of a Parkinson's disease hallucination. Now, the hallucinations can also include minor phenomenon like seeing something in your periphery, but when you turn and look, it's not there. Or a illusion, which is you see something and it's really there, but you misperceive it. So maybe somebody left a belt laying across the bed and a Parkinson's person perceives that as a snake. Or maybe they left a pair of white tennis shoes on the floor by the bed, and the Parkinson's person perceives that as white bunnies. So that's an illusion where they misperceive an object versus a hallucination when they're seeing something that is not there. Now, these tend to occur in the early stages of Parkinson's disease psychosis, and most of the time they don't frighten the individual. And this becomes a challenge because when do you treat? And I've always said that if I believe that my husband is now Brad Pitt, please do not give me an antipsychotic. I'm enjoying my hallucination. That is a challenge because in Parkinson's disease psychosis, we know that nearly 90% of individuals will progress from having a hallucination that they may be enjoying, that they may have insight, they may realize what they're seeing isn't really there, but they are enjoying it. So that's a hallucination with insight. And they will progress. 90% of them will progress in the course of 3 years to having disturbing hallucinations, things that frighten them, or to having delusions, which is always disturbing to the individual. And majority of them will need an antipsychotic to manage their symptoms. So it's now, we know that people that develop this psychosis will need treatment at some time for their psychosis, most likely with an antipsychotic drug. And it's up to us to determine when is it best to treat them. So let's look a little deeper. How common are hallucinations and delusions in people with Parkinson's disease? 50% of people with Parkinson's disease will develop hallucinations and delusions as their disease progresses. The older they are and the longer they've had Parkinson's disease, the greater the likelihood they will have a hallucination or a delusion. I have personally witnessed this in my family with my stepfather or with my father-in-law that has had Parkinson's disease. He ended up dying of consequences of late-stage Parkinson's disease. He did have delusions and hallucinations towards the end. And fortunately, I was able to engage with his direct care family. He lived in another state and his sons were close to him. And I was able to engage with them and explain to them what was going on. And actually, eventually, I got him to be seen by a movement disorder specialist, which is a specific type of neurologist that specializes in Parkinson's disease. And we were able to get him treated and keep him comfortable until the very end of his disease process. But this is very common, and we could anticipate that the majority of people with Parkinson's disease that are in our facilities and under our care do have hallucinations and delusions. The point is we have to assess for that. We have to ask them about that because it may not be real apparent. The delusions tend to get more apparent. The delusions are mostly persecutory. So they feel like somebody came in their room and stole something of theirs. And of course, any kind of allegation of theft in an institution, in a nursing facility or a hospital, we have to do a lot of research to validate that there was in fact a theft, in which case we have to report that, or to uncover that there was not an item that was actually missing. It takes a lot of staff time to investigate allegations of theft. And so these become very problematic, not just for the individual, the resident who is feeling that way, but also for the staff. We also know that people with Parkinson's disease psychosis have 3 times more physical and verbal behavioral symptoms documented on the minimum data set. They're 4 times more likely that those behavioral symptoms will negatively impact their ability to have social interaction or participation in activities. So they tend to become more isolated, or they're shunned by the other residents in the facility. They're 2.5 times more likely to resist care. So, and this is comparing PD with psychosis versus just Parkinson's disease patients. So the psychosis has a significant impact on the ability to provide daily care and to allow that person to participate in activities and to achieve their highest psychosocial functioning. There's also twice as many falls reported in people with PD psychosis. Imagine that. We know Parkinson's disease patients are already at high risk of falls because of their disease. They have slowness, they have postural hypotension, so they tend to fall more. And now have somebody with Parkinson's disease that feels the need to rush after somebody that they hallucinated, or to rush to get away from somebody that they hallucinated, or to lean over out of their wheelchair to pet the kitty that's not really there. So they tend to have more falls if they do have these hallucinations and delusions. So that can impact our 5-star rating if you work in nursing homes. So this is all just more reason to actively assess for and then treat Parkinson's disease psychosis. So how do we assess? Well, we have recently had, in fact, this was just published in 2023, the SAS-PAP, the SASPAP questionnaire, but it is the self-administered screening questionnaire for Parkinson's disease associated psychosis. This is a questionnaire specifically that you can ask any of your patients or residents that have psychosis or their family member if they're not able to really communicate. But the questions are simple. Have you misinterpreted something that you saw or heard? For example, thought a lamp was a person, or thought some sneakers were a bunny rabbit. You can fill in the blank for something that is appropriate for that person. So have you misinterpreted something you saw or heard? Have you sensed that someone or something was around you when nothing was really there? Have you seen, heard, smelled, or physically felt things that other people around you did not think were real? Or have you had thoughts or believed things that others did not think or believe to be true? For example, have you thought someone was cheating you or harming you or being unfaithful to you that other people didn't agree with? So these are just simple questions that you could incorporate into your quarterly care plan conference. Into any kind of an assessment. But the idea is that you do this regularly and you'll identify when these delusions and hallucinations start. Now, your nursing staff should be noting bizarre behavior, like a delusion or a hallucination, in their nurse's notes. But if you have seen them in the nurse's notes, then you could still do this questionnaire and get that into the clinical record. And that would support bringing the information to the prescriber so that they could do an evaluation and diagnose Parkinson's disease and psychosis. So if you find someone has Parkinson's disease psychosis, what do? Well, obviously you notify the prescriber, and then the prescriber is going to rule out any underlying illnesses that could be causing the psychoses. So for instance, they could be, well, there could be a urinary tract infection or a respiratory tract infection. And we know in our elderly population, we sometimes get delirium, which can be mistaken for psychosis. Dehydration can cause psychosis and hallucinations, nutritional deficiencies, thyroid dysfunction. So we need to get a good set of labs to rule out these underlying illnesses that could be causing the psychosis. We also need to rule out delirium, because delirium is not well differentiated from psychosis. And we know delirium is generally short-term and caused by any one of those underlying illnesses. So we get that addressed, and once that has been taken care of, we reassess to see if the delusions and hallucinations are still occurring. Then the next step is to optimize their Parkinson's disease medication. Now, we have known for decades that if you give someone too much dopamine, an overactivity of dopamine in the ventral tegmentum area of the brain will cause hallucinations and delusions. In fact, all of our antipsychotics, with the exception of one, all block dopamine. That's part of their therapeutic mechanism of action, is they block dopamine, because overactive dopamine causes psychoses. Well, if you have a person with Parkinson's disease, they have lost the dopamine producing neurons in parts of their brain. They have a significant loss of dopamine in their motor function areas, which is why we see the motor symptoms. So we give them drugs to add dopamine back into their brain. We give them levodopa carbidopa. We give them drugs that prevent the breakdown of dopamine, so more of it will stay around and they'll have more of a response to dopamine. And sometimes that can worsen psychosis. So the first thing we do once we start looking at drug therapy is try to optimize their Parkinson's medication that is trying to introduce dopamine back into the brain. But I will tell you, we can't take it all away. If we take all of their dopamine drugs away, then they freeze up and they have no quality of life. They're just basically laying in bed frozen. So we have to keep some Parkinson's medications on board, but the consultant pharmacist, we know that frequently will recommend that dopamine agonists are decreased or removed, and sometimes we will make adjustments in their Cytomet levodopa carbidopa medication to try to get them on one that's more long acting, so we don't see these bumps in dopamine in the brain. We also would like to reduce other drugs that can cause psychosis, like anticholinergic drugs, opioid analgesics, muscle relaxers. Those are the categories that come into mind. MAOA inhibitors, tricyclic antidepressants. We really take a focused approach to address the various medications that our people are also on, to try to get them on the cleanest, most optimized medication regimen, and then reassess the psychosis. So at this point, we've tried non-pharmacological approaches like managing underlying diseases, and we have tried non-pharmacological approaches, at least from the perspective of adjusting or discontinuing medications that might be contributing to the psychosis. Eventually, though, most people with Parkinson's disease psychosis will need treatment with an antipsychotic. And there is only one antipsychotic that is FDA approved to treat Parkinson's disease psychosis, and that's pimavanserin. We'll talk a little bit more about that in a minute. So let's address these non-pharmacological approaches first. And for any nurses on the call, this is a very important aspect of your management approach to Parkinson's disease psychosis. So here are some things we can do, whether they live at home or whether they live in a nursing home or assisted living. We can improve lighting. So some things that are very specific for psychosis with Parkinson's disease is that they tend to have their psychotic episodes when they are in quiet, dark areas. It's like in the afternoon when everybody else is napping and nothing much is going on at the facility, no activities, it's quiet, it's starting to be sunset, and they tend to have more of their visual hallucinations at that time. So increasing the lighting, reducing shadows in dark areas is one way that we can approach this from a non-pharmacological perspective. Making sure that the resident has proper glasses and hearing aids. If they've lost their glasses, then goodness knows, everything they see could be a hallucination or an illusion because you don't have enough lens activity to really clearly see what you're looking at. And hearing aids, you can hear things that are not there if you don't hear correctly. So making sure that they have their own hearing aids and glasses and that their vision and hearing has been checked recently would be good for helping reduce hallucinations and delusions. Reducing clutter. If they see a belt thrown across the bed or shoes on the floor and they are perceiving those as an animal or a reptile, then making sure things get put away so that there's not so much clutter for them to look at. Removing mirrors if you can, or reflective surfaces, because that can cause confusion with people with Parkinson's disease. And then ensure consistent and familiar surroundings because sudden changes can worsen psychoses. And we should know this. I mean, these are not that different from what we do to manage our dementia residents to reduce agitation. So these are very similar things we're already doing, and we should document that we are using these approaches as part of our non-pharmacological approaches. We also have some behavioral and cognitive approaches that are worth visiting. So, and again, we do these same things with our dementia residents. Reality orientation techniques, gently reorient the patient without arguing about the delusions. Don't, if they believe something that is not true, if they believe somebody's been stealing their belongings, just very quickly say, yes, we will look into that, and then reorient them or redirect them. So yes, we will look into that. I'm going to have Nurse Mary and so go into your room and verify with that. You can come with us, or maybe you'd like to go to bingo. Avoid confrontation. That's the number one thing. Don't ever tell a resident that believes something that it's not true, or try to tell them something else is true, because that just causes conflict. And the more conflict, the more agitated they get. And then validation therapy may work for some people. It may work for non-threatening delusions where you acknowledge their feelings without challenging their belief. So these are just normal behavioral cognitive approaches that we're already doing. We might not be documenting it, but we're already doing it with so many of our residents. And so again, these should be documented as part of our non-pharmacological approach, because the new 605 regulation, where psychotropic drugs now reside or will reside whenever those go into effect, which right now are going to be the end of this month, but we'll see. But 605 has expanded its discussion about non-pharmacological approaches and how much we need to document on that before we choose to use an antipsychotic drug. All right, now get back down here and move to the next. All right, so pharmacological treatment. What we understand about Parkinson's disease psychosis is that there are 3 interconnected neurotransmitter systems that are involved in the development of hallucinations and delusions. It's not just dopamine. I talked a little bit about dopamine, and we have for decades believed that overactive dopamine or too much dopamine in the brain causes hallucinations and delusions. And that's why all the antipsychotic drugs, except for pimavanserin, which is Nuplazid, all the other ones block dopamine to some extent, because we thought that was an important part of treating psychosis. It turns out with Parkinson's disease psychosis that it's not really driven by dopamine. We have a patient with Parkinson's disease where they have an overall lack of dopamine in their brain. So if they have not got enough dopamine to be able to function, how could that be causing them to have hallucinations and delusions? It turns out it's not the dopamine. It really is serotonin. And the serotonin becomes, and it's particularly the serotonin 2A receptor, becomes hyperactive in these individuals that have Parkinson's disease and a lack of dopamine. And I've got a graph I'm going to show you in a minute, but I want to talk to you for a second about the receptors in the brain. This is a very simplified graph, but ideally, the ideal drug would be a drug that only impacted the one receptor that was responsible for a condition and did not block any other receptors. That would give us a laser focus for the therapeutic action without any risk of adverse effects. Now, all antipsychotics, with the exception of pimavanserin, Nuplazid, block multiple neuron systems in the brain. So if you block muscarinic or acetylcholine receptors, your adverse effects will be cognitive impairment, disinhibition, mania, antisocial behavior, euphoria, tachycardia, and constipation. So if you give a drug that is an anticholinergic drug, these are the adverse effects that you should plan for. And they're more prevalent if you block all four of those acetylcholine receptors. If you block histamine receptors, you'll get sedation, particularly histamine 1. If you block adrenergic receptors, particularly alpha 1 and alpha 2A, you'll get orthostatic hypotension and falls, depression, and low energy. If you block dopamine receptors, particularly D2, you'll get movement disorders like Parkinson's disease, endocrine changes, but that is also how you get your antipsychotic effect, is by blocking D2 receptors. And then if you block serotonin receptors, if you block serotonin 1A, you have an anxiolytic effect. And if you block 2A, you get an antipsychotic effect. So if you needed to give an antipsychotic effect that did not cause any other of these adverse effects that you saw, then developing an antipsychotic that just focused on the serotonin 2A receptor might be an avenue to approach. And that certainly was the avenue that pimavanserin took. Now, we do know there are different types of antipsychotics. If you look at the generic names, if the name ends in sarin, like pimavanserin, it primarily works on serotonin 2A. It blocks overactive serotonin 2A with a little bit of activity at 2C. If it's a pene, like clozapine, my goodness, it blocks everything. Or olanzapine, or quetiapine. Quetiapine is the most common antipsychotic used in long-term care. But look, it ends in pene, and it blocks all of those receptors. So if I went back to that previous slide and you thought, okay, anticholinergic, not good. Histamine, not good. Adrenergic, not good. All of a sudden you see that quetiapine is not that great of a choice for very many people. Now, hold on to quetiapine. I have something else to tell you about that. But then the risperidones, the dones, they block a lot of dopamine. They also block serotonin. And then the pips and rips, caripiprazole is one of them. You might not be familiar with them very much. We don't use them that often, but they also block a lot of other receptors. One thing you'll see is that all of these block serotonin 2A, and that is what makes them a second generation antipsychotic. So you have your first generation and your second generation. And so I'm talking about all the newer antipsychotics here, but there's only one antipsychotic that just focuses on serotonin 2A, and that's the pimavanserin that we have on the market. I was talking about how you could predict adverse effects based off of how many neurotransmitter systems that type of drug blocked. This is just another chart that shows you by number of stars. The more stars, the more activity it is. So clozapine causes a lot of, which is the second one here, causes a lot of sedation, a lot of anticholinergic, a lot of constipation, a lot of blurred vision, a lot of hypotension, a lot of weight gain, and has a lot of metabolic effect. Olanzapine, a little bit better. Quetiapine, it's a little less, but it still does cause sedation and anticholinergic effects and hypotension. But pimavanserin, the one in the white there, it doesn't have any of those adverse effects because it doesn't block any of those neurotransmitter system. It only blocks serotonin 2A. All right, so enough about that. It only blocks serotonin 2A and a little bit of activity at 2C, and that's what makes pimavanserin different from all the other antipsychotics, and what makes it particularly useful for people with Parkinson's disease, because every other antipsychotic that you see here blocks dopamine. Every other antipsychotic is blocking the very receptor we're giving levodopa-carbidopa to address. So it's like, makes no sense at all to give any other antipsychotic to a Parkinson's patient that you're giving levodopa-carbidopa to, because you're basically, you know, you're filling up the glass halfway and then pouring it out, and nobody ever gets to drink. So pimavanserin, only drug that is effective by just blocking serotonin receptors. Now, I told you I had another slide for quetiapine. All of y'all have experience with quetiapine. You go, well, gosh, it doesn't seem like that bad of a drug, but you're using tiny doses of it. So at doses of 25 or 50 milligrams, quetiapine is primarily an antihistamine, like Benadryl. You see Baby Bear there? It's got the histamine receptor, and you get sedation. So if you use 25 or 50 milligrams of quetiapine, you're putting that person to sleep. If you get doses up to 300 milligrams, you get more of an antidepressant effect. You are starting to get some activity at serotonin 2A, but you're getting more of an antidepressant effect. You have to get up to doses 600 to 800 milligrams a day of quetiapine to get a true antipsychotic effect. So if you're using quetiapine to treat people in your facility with Parkinson's disease psychosis, all you're doing is putting them to sleep. Now, I'll be the first to say that if their psychosis is keeping everybody up at night, and you give them a quetiapine 25 or 50 milligrams, and they sleep through the night, you might consider that a therapeutic win. You might consider that a therapeutic activity. It's not. You're simply putting them to sleep. And when they wake up, they will still have their hallucinations and delusions, but at least they're perhaps easier to manage. Oh, but I just said easier to manage. That's sort of like nursing convenience. And that convenience word is mentioned frequently throughout the new 605 language. If the only reason you're giving a drug is for the convenience of staff, then that is a chemical restraint. So using quetiapine at 25 or 50 milligrams because it's putting the resident to sleep and it's making him easier to deal with, that is a chemical restraint. Treating them with an antipsychotic dose that would actually lessen the frequency or the intensity of their hallucinations and delusions, that would be a therapeutic effect. However, if you used quetiapine at that dose, they would get so much anticholinergic, histaminergic, and adrenergic effects that it would be an intolerable product for them to use. So I just wanted you to understand how this now plays into the new 605 language of moving psychotropic drugs into chemical restraints. Now, there is one other drug that is recognized in the compendium as being effective to treat Parkinson's disease psychosis, and that is clozapine. Both clozapine and pimavanserin are considered both efficacious and considered clinically useful. And clozapine has had its REMS program essentially removed. So it's easier to order and administer, but it still does have a risk of neutropenia. So you would still need to do lab work on a routine basis for clozapine. And clozapine blocks it's a pine. It blocks every neurotransmitter system. So while it is effective in treating Parkinson's disease psychosis, you will get every adverse effect if you use clozapine. Now, there are some people with schizophrenia that clozapine is the only thing that works. And it's a good thing we have it. But if we're treating Parkinson's disease psychosis, pimavanserin would be a better choice. And that's what you see in this chart below. This chart comes from the Movement Disorder Society, which is a segment of the American Neurological Association. And the Movement Disorder Society updates their treatment recommendations for Parkinson's disease psychosis fairly regularly. The last update was done in 2019, and there have not been any new drugs on the market since then. But they basically said that quetiapine was essentially not effective. They said there were 5 trials comparing quetiapine to placebo, that it was equal to placebo. And there were 2 trials comparing quetiapine to clozapine that showed that quetiapine was better than clozapine, but there's just no consistency. And so their recommendation is not to use quetiapine because there's insufficient evidence. And pimavanserin is the only drug that is both effective, clinically useful, with an acceptable risk. So we really only have one choice when it comes to treating Parkinson's disease psychosis. That's why I've left the last 5 minutes to talk about pimavanserin, and then we'll have some time for Q&A, because this is really the only choice. So I hope that I've gotten you maybe to think twice about quetiapine. If you're using quetiapine as your primary antipsychotic in your nursing facility, particularly to treat Parkinson's disease psychosis, you need to now consider whether or not that may trigger a chemical restraint under 605, because they're not getting an antipsychotic dose, they're only getting sedation, which could be considered for staff convenience. So just be aware of that. Now, pimavanserin is effective. This was the clinical graph and I borrowed this from Nuplazid, so I realized I forgot to blank out Nuplazid. So please forgive me, I should have blanked that out and made it say pimavanserin. But basically, it was effective in as little as 4 weeks, and it continued to be effective in 6 weeks. So one thing you need to learn about pimavanserin, it is not a sedating antipsychotic. So it's going to take at least 4 weeks before you can make a determination as to whether the person is going to respond to pimavanserin or not. You're going to need to give it for at least a month. And 34% of people saw an improvement in their hallucinations versus just 18% on placebo. 41% saw an improvement in their delusions. 65% of people had a noticeable response to treatment. And that's what this slide says, is that 65% of people had a noticeable response. Altogether, about 75% of people did have a response to treatment. 65% of them had a noticeable, meaning clinically evident response. 14% of people went into complete remission. So what should you be looking for a response? Because you do need to document if a person starts taking a drug, if they have an improvement or not. And the improvement you're looking for is a reduction in the frequency of hallucinations or delusions and the intensity. So maybe they've only ever had 2 hallucinations a day, and they're still having 2 hallucinations a day. But if they were hallucinating a monster was coming after them, and now they're hallucinating children playing outside, that would be a reduction in the intensity. So that's the degree of information we need to try to gather from a person when we start them on any antipsychotic, and when we start them on pimavanserin. That's what we would expect to see. I will say 25% of people did not respond. So there is no one antipsychotic that's going to work for everybody. So if you do try pimavanserin, you need to give it for at least a month, maybe give it for 2 months. And then if there has been no change in that individual, you need to discontinue it and consider, in this case, clozapine would be the only other compendia approved treatment. But you can try something else. But most people will respond to pimavanserin. We also know that with pimavanserin, they specifically looked at whether or not it would impact motor function. Remember, people with Parkinson's disease have motor problems because they've lost all the dopamine-producing neurons in the basal ganglia and the substantia nigra specifically, but in the basal ganglia. And that's where what did I just do? That was pretty cool, wasn't it? Hang on a second. See, I can't find the word I want to say, and I just totally went through all my slides. But, oh, look at this again. This is the easy way to get back there. So what I was saying is that with pimavanserin, they tested whether or not there'd be any movement. If you give any other antipsychotic that blocks dopamine, you are going to worsen motor function because you have very little dopamine available. And if you start blocking the receptors that the Sinemet is trying to get to, you're going to worsen motor function. So they looked specifically at pimavanserin, which does not block dopamine and therefore would not be expected to worsen motor function. And what they found is that both pimavanserin and placebo both slightly improved motor function. So this is the only antipsychotic that can show that it has no negative impact on motor function, and it would make it ideal for people with Parkinson's disease. All right, let me talk 2 more things. Gradual dose reduction. Gradual dose reduction must be considered on every psychotropic drug, and with antipsychotics, there are specific guidelines. So you should consider at least once a year. And if it's the first year that someone's on a drug, you should consider it twice in the first year about whether or not they still need to stay on that same dose or be on that drug. Have they had an improvement in their symptoms? Remember, 25% of people don't respond to pimavanserin. If they don't, then you discontinue it. That counts as a gradual dose reduction because you have discontinued a product that they were not receiving a therapeutic benefit from. But if the excuse me, if the individual is responding to pimavanserin, then we are fortunate that the regulations, now F605, the regulations do specifically say that Parkinson's disease psychosis is an enduring and progressive condition that may need treatment indefinitely. This language has been in the regulatory language since the 2017 regulatory update, but it was under 758, but now it's under 605, but the language is still there. If somebody has Parkinson's disease psychosis, the physician still needs to document that he's considered a gradual dose reduction. But if the resident has an enduring and progressive condition, if they are still having some hallucinations and some delusions, but have responded to pimavanserin, both by reducing intensity and frequency, and they're not having adverse effects of the pimavanserin, the physician can say that it would be clinically contraindicated to reduce the dose at this time. So if you're a consultant pharmacist, I would recommend that you don't just send out that open-ended, it's been 6 months, it's time to do a dose reduction, time to do a GDR. You, as a consultant pharmacist, need to actually look at the resident, at their profile, read their chart. Are they responding to therapy? Is this a good thing for them? And are they having adverse effects? No? Well, then maybe you don't recommend that it's time to do a gradual dose reduction. You recommend, doctor, it appears the resident is doing very well on pimavanserin, and this is a progressive disease. Would you like, it's time for you to write a clinical contraindication. I mean, let's tell the prescribers what they need to know to take good care of our residents. And just stopping an antipsychotic that they're actually getting a response to is not good care. CMS has verbally said in a number of different times, they don't expect antipsychotic rates to be 0. They know people in nursing homes need to be treated with an antipsychotic. What they want it to be is that we've exhausted non-pharmacological mechanisms, that they're on an antipsychotic that is approved to treat their condition or is the best choice to treat their condition, and that people are looking to make sure that they're getting a good therapeutic outcome and they're not having adverse effects. That's what CMS's intent is with this regulation. So the last couple of things I want to tell you, we do have QT prolongation with every antipsychotic. Pimavanserin is no different. So if you're giving the drug with a known blocker of the QT interval with the heart, you might want to be aware of it. But pimavanserin by itself was very mild. It only increased QT interval by 5 to 8 milliseconds. So by itself would not cause a problem. But if you give it along with other drugs that also prolong QT interval, you might want to see whether you can make adjustments of those other drugs, or just be aware. Strong CYP3A4 inhibitors, we have a dose of 10 milligrams once a day. Otherwise, everybody gets the same dose, 34 milligrams a day. That's the only dose. Less than 34 milligrams a day is not effective. Unless you're taking a strong CYP3A4 inhibitor that inhibits the metabolism of pimavanserin, in which case you give the 10 milligram tablet. But the 10 milligram tablet is not a step down dose to do a gradual dose reduction with. And yeah, there's no titration. Everybody gets 34 milligrams. You can open and sprinkle the contents out of the capsule on applesauce or condiment of choice. That's actually in the package insert. So if a surveyor were to question you, you could show them the package insert. And the other thing is pimavanserin can be used in people with Parkinson's disease psychosis, whether or not they have dementia. So if they have Parkinson's disease psychosis and they also have dementia, you can use pimavanserin. It makes it the only antipsychotic that in the package insert, in the indication, it says that it can be used in people with dementia. Now, every antipsychotic has the box warning that you can't use it to treat psychosis associated with dementia without being at risk of increased mortality. But with pimavanserin, it's the only antipsychotic that you can treat Parkinson's disease psychosis with, even if they have dementia. That's a big distinguisher. All right, let me give you some takeaways, and then we'll have a minute or two for questions. But for the nurses that are online, the biggest takeaways that I can recommend is to routinely screen all residents with Parkinson's disease for signs and symptoms of psychosis. if you see something, say something. Nurses and other facility staff, they're hugely important in recognizing that a behavior the resident may have may be because he's interacting with a hallucination. He's leaning over all the time, reaching down. Maybe he's petting a hallucinated dog. We need to ask about that. If they're suddenly very, very agitated, we need to understand the cause of the agitation, because it may be that he thinks somebody has come into his room and stolen something that's important to him or her. So yes, we need to assess better. We also need to know that pimavanserin does not support a dose reduction. We do need to document if it's clinically contraindicated to do a dose reduction on a yearly basis or twice during the first year. But there's only one dose. You're either on pimavanserin or you're off pimavanserin. If you're on pimavanserin 34 milligrams and you're getting a therapeutic response, there's no dose to reduce. That's the only dose. And it is the only FDA approved indication. And I know we all have heard of the Beers criteria. The 2023 Beers criteria specifically states that pimavanserin is the only antipsychotic approved to treat Parkinson's disease psychosis, and recommends avoiding all other antipsychotics, including quetiapine, in people with Parkinson's disease psychosis. And we know the Beers criteria are often referred to by surveyors when they are doing a medication evaluation. All right, what are some pharmacists' key takeaways? Well, pimavanserin is covered by 100% of Part D plans because it is in a protected drug class. There are some plans that may require a prior authorization. And if they do, all they want to know is, does the resident have Parkinson's disease, any one of these 5 or 4 G codes for Parkinson's disease, and do they have psychosis, either delusions or hallucinations? So we have 2 codes for psychosis. So they need to have a Parkinson's disease diagnosis code and a psychosis diagnosis code. And then the plan is going to cover pimavanserin because it's the only FDA approved treatment. A GDR is not appropriate. We already mentioned that as a nurse takeaway. But when you make a GDR recommendation, I've already said this, don't recommend that they stop the drug. If the resident is still getting a benefit from them, let the prescriber know in your recommendation that they can say it's clinically contraindicated, but what they need to write, they need to record that the resident is continuing to get a benefit from therapy and that they've considered the adverse effect profile and the benefits outweigh the risks. That's what they're looking for in a proper GDR documentation. And you as a consultant pharmacist can let the prescriber know what your perspective is. And then pimavanserin is the only treatment for PDP that does not block dopamine receptors. And last but not least, as 12 o'clock hits as the clock starts striking 12, administrators, you need to know that CMS does not expect antipsychotic utilization rates to be 0. Hallucinations and delusions associated with Parkinson's disease may eventually require treatment with an antipsychotic. That is well documented in much literature. And the other thing is that treatment of PDP with pimavanserin is not a chemical restraint, unlike quetiapine, which could be considered a chemical restraint. Pimavanserin does not cause sedation, and that's a big part of determining if a product is a chemical restraint, is does it cause sedation? And hallucinations and delusions place the resident at risk for falls and causes resident distress. And that's a key indicator about whether or not something is a chemical restraint and being used for staff convenience, or whether it's meeting a medical need. And in this case, pimavanserin is the right choice. So I know I went all the way to 12 o'clock and I've been doing all the talking, but I've been looking at the chat and I haven't seen any questions come in. So if anyone has any questions, you can put them in the chat or ask me. Or if y'all are just itching to get back to work, I understand. I appreciate that you came out and spent an hour with us today. And I'll turn it back over to Mike. So we have 2 questions. But I don't see
You're
the
on
2.
top of those questions, Dana?
I don't see them. You want to read them out to me?
I don't see them. I just see 2 questions.
Looks like they're frantically typing their 2 questions. So
Okay, all right.
give-
Well,